We know the next speaker because she's been on the panel, Dr. Sandy Springer, and she's going to talk to us about substance use disorder issues that were addressed in the guidelines. She's professor of medicine in the ID section at Yale School of Medicine. Sandy, welcome.
Thank you. These are my disclosures. So a lot of what we're going to be talking about, or what the discussions are going to be, as Mike was saying, are just basically things that we should know about substance use and substance use disorder in particular, mainly opioid and stimulant. And then I'll touch upon some of the guidelines that we came up with new things. So as much as I would like to discuss many things about this upcoming case that we're going to just, there's a few points that we wanted to make that are new in the guidelines. Specifically, as an ID provider, I'm sure if many of you are ID docs, this case is probably very similar, and this is actually a true case and contemporary. So this is a 30-year-old female with HIV, major depression. She presented to the emergency room with 2 days of nausea, vomiting, left hip pain, and fever. She's found to be tachycardic, hypotensive, basically septic appearing, febrile. Multiple wounds are identified on her arms and legs. And of course, she gets blood culture. She started on antibiotics, typically Vanc and Zosyn, and she's admitted to the floor. If you scroll through her EPIC chart, there's been multiple ER visits with skin and wound infections, possibly related to injection drug use, but importantly, within the chart, there's no specific diagnosis of a substance use disorder. She has documented as having had HIV for many years, over 10 years, currently prescribed bictegravir-based FTC TAF. And there's also, importantly, multiple no-shows in her EPIC chart, but not really any documentation about where she is. Her last viral load was over 55,000 copies. So she's admitted to the floor. Blood cultures turned to be MRSA. ID recommends left hip aspirate, typical evaluations for endocarditis, CTE, restarting her antiretroviral therapy, and a wound care consult. The next day, her left hip is identified fluid as MRSA, and the plan was to take her, as is recommended, to get her left hip washed out for septic arthritis. But she's appearing very anxious. She's visibly sweating. She's persistently nauseous. She's vomiting, having diarrhea. And she really is stating to the medical team she has to leave the hospital right now. And they told her, you have to stay. You have to go to the to get your left hip taken care of. And she self-discharged. So we call this self-discharging, previously been identified as leaving against medical advice. The term now is self-discharge. So there's a lot of things we could talk about this case, but this is a contemporary case occurring in the hospital at Yale. So this is just a basic question, but what additional recommendations could the hospital team have said to her before at the time of her self-discharge? And there's a lot of things, but I only have 4 choices. So A, call hospital security. B, prescribe naloxone. C, call psychiatry for assessment for medical competency. And D, there's really nothing you can do because she's planning on leaving the hospital and does not want your medical care, apparently. As your thoughts? So yeah, 61% said prescribe naloxone and 35% said to call psychiatry for medical competency. And 4% said nothing you could do. And fortunately, 0 said call hospital security. So, there's a lot of things we could talk about here, but I just was wondering if anyone on the panel had anything to say about the situation, or if you had similar experiences and any recommendations that you would make about this case.
As you said, this comes up pretty frequently, and it's really important to be prepared. I think prescribing naloxone makes a lot of sense to me in terms of, the only chance to really help someone is if they can stay alive. And so I think we do need to try to work to help prevent overdoses, and naloxone is I think is important to prescribe. One thing I would also say is there are data showing that giving oral antibiotics to someone who leaves prior to completing a course of therapy is certainly better than no antibiotics at all. So we've started being more proactive about thinking with the medical teams when we're doing consults about oral options for antibiotics. And that's not the question, but just something to throw in there is given her infection, that's another part of her care.
Right.
And I would add, Sandy, that frequently here, what you need to look at is also why did this happen, right? And frequently is the stigma and the way patients with substance use disorder get talked about and get treated in the hospital that makes
Right.
them uncomfortable and wanting to leave and don't feel comfortable. So part of it is developing the kind of relationship with the patient and setting goals from the beginning, as opposed to being you frequently hear disparaging words and comments on these patients, and that, of course, the patients feel it and they want to leave.
Right. Yeah, so all those comments, and yes, Raj, definitely, there's a lot of data for providing oral antibiotics, especially in this particular situation. But this shared decision-making process, and then what you hit upon is this person, no one has actually asked yet. It's presumed she's using drugs, but no one's actually asked her yet. And so, but she does have a history of depression, and there's a concern that that might be the case. But the question is, or well, not the question, but the idea is that we need to be assessing substance use and asking her the question. But yeah, naloxone definitely would help to prevent an overdose death. And this idea of this shared decision-making process, and we'll get to the other issue about why she's feeling so anxious.
But I think also, I'm sorry, it's also very important to support the patient, to give to support in this maybe just difficult life situation, and to understand the whole situation, not only to prescribe the naloxone. It's just one step, but you have really to see the whole patient in the whole situation. This is
Right.
something very important.
Yeah, absolutely. And that we'll dive into that a little bit more. But it's really important to ask what particularly is the reason for why she feels like she has to leave the hospital, and are there other things that we could be doing? And importantly, this person has HIV and has been having difficulty, what we think, with coming to appointments and taking her medication. Her viral load, the last we knew, was detectable. Plus, now she has another infection. More than one infection, at least, that we know of. So really important. So just to make the point, I'm just making one point at a time, but there are a lot of missed opportunities to prevent an overdose. So she is at high risk of overdose. So leaving a supervised setting, hospital, prisons, jails, are significantly high at risk of overdose. So the concern is, and we'll get to this, that she may have a substance use disorder. And one of the things that we need to think about are, what are other reasons why individuals are coming into contact with the healthcare system, and many of which are related to, non-HIV, but other infections. So wound infections, bacteremias, infectious endocarditis, septic arthritis, epidural abscesses. And those are definitely points where we should be assessing substance use and substance use disorders. And importantly, if they are in the situation where they are staying, or whether they're upon discharges, whether we're going to be initiating, which we'll talk about later, treatment for a potential substance use disorder, is also helping them prevent a overdose death. And this is data from our Centers for Disease Control that we've had, and the data that they had from over 30 jurisdictions in 2022. There was evidence of close to 65% missed opportunities. And when we look at, for this particular patient, 26 or 27% missed opportunities in those that had a known mental health diagnosis. So this patient also has known major depression. And then individuals who are released from an institutional setting, which this patient is being right now, or she's self-discharging. And we haven't even gotten to the point, has she had prior overdose events? And is she currently, or has she been on any substance use disorder treatment? So really, everybody, I carry naloxone on me. All my staff carry naloxone, because you just never know. It may not be a patient, you may be wherever you are, but in the United States, it is now available. Naloxone does not require a prescription. It is available in many pharmacies. However, many of our patients can't afford it. So that's another issue right there. I think the other issue too is there are other harm reduction tools that we should be providing. This is a vending machine in DC when I was walking by it one day, and there's lots of folks allowing people to utilize these services, but clean injection drug works, safe injection education, safe injection sites. And then also for those, right now, fentanyl is our only opioid mainly, but xylazine is another drug, which I'm going to talk about, that we do have drug testing strips for xylazine that are important. And really just giving guidance to individuals who may not know, or their partners, other individuals that are with them, on how to recognize an overdose, and really clearly identifying how to administer it. So we have the intranasal formulation, which is easy to use, how to use it. These are pamphlets that we developed that others can copy. And you can see the website down below about how to do this. Some people like the actual handouts. Some people you could show them if they have a phone or another device that they could download that, but also their partners. And then how to use drugs safely. So we can't make everybody stop using drugs, but how to safely use drugs and how to safely clean their materials. And so these are other pamphlets and other materials that you can use that are important. And also using these as a point for those who may not be aware that there's increased risk of not only routine infections that we're familiar with, but also if they don't have HIV or hepatitis C, that there's a risk of acquiring those as well. And I just wanted to point out for xylazine, for those who don't know, what is it? It's an alpha-2 adrenergic agonist, a similar mechanism to other drugs like clonidine. It's predominantly used in the US for veterinary sedation, and some of the street names are trank. Some have referred to it as zombie or trank dope. And we're seeing more and more that xylazine is associated with overdoses that people may not be aware of. In Connecticut, where I'm at, xylazine is very common. And it's not just adulterant in illicitly manufactured fentanyl. It's a drug that you can identify. You can actually purchase. It's known, and unfortunately, it mimics the same overdose events that you might see in someone who's using opioids. So it's hard to differentiate. We still recommend to give naloxone, but also importantly to give rescue breaths. And it's really associated with additional symptoms and signs of wound infections. So this woman has been coming to the emergency room with multiple wound infections and may have been a sign of xylazine use. So this particular patient was injecting xylazine in addition to illicitly manufactured fentanyl and cocaine. But there are many who don't know if they are receiving xylazine. And this is just some data from the CDC showing on the left-hand side overdose deaths associated with illicitly manufactured fentanyl. In the solid blue line are the number, and the dotted line is the percentage individuals who have xylazine co-involved or detected in their urine with illicitly manufactured fentanyl. And this last was May 2022. And then the graph on the right is looking at the states, and you can see like Connecticut and New Jersey were having significant overdose deaths related to that, over 150 per, as you can see in the darker green. So it's increasingly becoming associated with overdose deaths, but also sadly interfering with treatments for opioid use disorder and other situations and interfering with, for those who have HIV, interfering with HIV care. This is just to show you what some of the xylazine wounds look like. And this is a case study where they were able to detect that these were directly associated with xylazine. And so this could be a tip off too for you. And they're treated very differently. And I don't have time to go into that, but more petroleum-based wound care and others. And then there's also a risk of superinfection, and they can happen more distally from where persons are actually injecting. So having a necrotic kind of look. So this particular woman had been coming into the emergency room for these types of wounds, and this would have been a reachable moment also for her early on in prior stays. So we added this. This wasn't with our last guidelines. So in highlighted here, we recommending that all individuals who are at risk for HIV or who are currently living with HIV don't forget to provide harm reduction services, and as well as and other things that we've discussed. So so now we get to the patient. So she's looking significantly unwell. You have her on antibiotics. She's on IV fluids. You've recognized that she needs to have a washout of her hip, but she's having nausea and diarrhea and anxiety. So how would you manage this? Basically, the question is what is the problem and why is she experiencing this? Are you going to call GI because she's having nausea and diarrhea? You're going to give a benzodiazepine for anxiety? Are you going to, maybe you think this is another infection, so you have to change her antimicrobial regimen. However, she's on vancomycin and piperacillin tazobactam. So what other things might you add? Or the last choice is provide an opioid. Yeah, so benzodiazepines, maybe change your antimicrobial regimen and provide an opioid. So I left that pretty open, but anyone, so I guess the question is, you know, what we're managing here. So, and why she felt like she had to leave the hospital. And
Well, I can jump in if you can hear me.
yes.
This is opioid withdrawal, and the question for me is just give her a regular old everyday opioid or jump right into buprenorphine if she's wanting to get off of her dependency on opioids. So you and I have talked a lot about this in the last 6 to 12 months, and I'm impressed with the changes in the recommendations, which I know you can go over better than me.
Yeah, so it seems pretty easy. It's opioid withdrawal, and we could have prevented the opioid withdrawal if we'd identified her opioid use disorder for when she came in. Again, she hadn't been identified, and this is a very common situation, unfortunately. But way back when, not that long ago, that is how we managed individuals who had what we used to call opioid dependence, was providing an opioid. In fact, the best data for opioid use disorder treatment and management of withdrawal is with methadone, a long-acting opioid, very effective. In the United States, the two main treatments for opioid withdrawal are buprenorphine, like you were saying, Mike, and methadone, a longer-acting opioid, and can be initiated in the hospital setting very easily. But unfortunately, it seems easy because in a question, but it's often missed. And unfortunately, this is a very common scenario for why people self-discharge and cannot stay in the hospital to finish even a very serious infection treatment, in this case, septic arthritis. We don't yet know if she has infectious endocarditis too. So yeah, no, this is I don't know if anyone else wants to comment before I go on. So one of the things we recommended, this was in the prior guidelines, but some of you may not know about the supplemental material. So just as like just to remind people, there are the supplemental tables that you can find in you click on the link, I think, in the paper, but how to first diagnose. So you could refer to psychiatry, but really the key is that we should be able to diagnose or understand that someone might have a substance use disorder. And this is just some of the tools, including those that are provided by NIDE and National Institute on Drug Abuse for free. And then there have been some tools for developed that are rapidly can diagnose in less than 5 minutes substance use, in particular opioid use disorder and stimulant use disorder. And then of course, alcohol use disorder. So just bringing your attention to those. The other thing is there are scales to recognize opioid withdrawal, which is what this individual was experiencing. So in here, you know, this individual is notably sweating, she's restless, she's having nausea and vomiting, she's very irritable. And you add those up and you can determine the level of withdrawal. And anything moderate to severe, well, anything mild to severe can necessitate treatment with buprenorphine or methadone to help alleviate the withdrawal. And the whole point is you want to help that person treat that opioid use disorder so that they can stay in the hospital, finish their completion of their treatment, and eventually, hopefully, we can talk about her HIV disease. So very easy to do. So if you're not sure, this is something you can download on your phone. This again, I'm not going to go into detail, but just pointing out that in the supplemental document, there is a table for the 3 FDA approved medications that actually have significant amount of data that not only improve opioid use disorder outcomes, so reduced opioid use and overdose deaths, importantly, but also can improve HIV outcomes. So among those who have HIV, can improve viral suppression rates, and among those who don't have HIV, reduce HIV risk behaviors, injection drug use, and condomless sexual intercourse. And the 2 methadone and buprenorphine that are both opioids can manage withdrawal as well. Extended release naltrexone is a long-acting opioid blocker, so don't want to give that for withdrawal. It's like a long-acting naloxone, but could be effective in some individuals who are not currently using opioids. We also have a table for alcohol use disorder. And then, Mike, this was just getting at what you were talking about. You can initiate buprenorphine in the hospital when they're in withdrawal, very easy to do. Assume everybody has fentanyl right now and really high doses. You don't wait. High doses, 16 to 32 milligrams typically that first day are really what patients are needing. And if you go slower, they're more likely to persist with their withdrawal symptoms and unfortunately have to probably leave. So this is also discussed in the International AIDS Society USA substance use disorder recommendations, a live webinar that was developed. So if you want more, you can go to the website and review those presentations. And this is just for your reference. There are ways to initiate buprenorphine while individuals are continuing to use opioids. So you don't need to wait for them to go into withdrawal. And I don't have time to go into all of that. And there's also importantly data to really good data, not just from our group, but many others showing that you can initiate long-acting injectable buprenorphine, a 30-day supply in 1 injection in people who are continuing to use fentanyl in hospital settings, so within the hospital as well as in the emergency room and also in community places. So another thing to think about. And this is also just to point out in your supplemental materials within the new guidelines, we provided how you could a handout that you could give to patients if you're in the outpatient setting and how to initiate buprenorphine while individuals are either continuing to use opioids or not. So that just to point that out. So now we have switching the case. You've done your job. You've given her buprenorphine. She's now on her, she's stayed. She's getting her rest of her antibiotics. But as you talk to her, you find out she's continuing to use cocaine that someone's bringing in with her food. So what would be the appropriate next step? Call security. Tell her she can no longer have visitors. B, stop buprenorphine because she's using a stimulant. C, switch her buprenorphine to extended release naltrexone, or D, continue buprenorphine and offer contingency management and other medication support for cocaine craving. And the polls. Oh, that's good. So there was a trick there, but for extended release naltrexone, but yeah. So I don't know if anyone wants to comment on continued, well, in this case, stimulant use in the setting of treating her opioid use disorder. If anyone's seen this. It's tough. It's tough to manage. I don't know, Carlos, if you had any comments.
This is very tough to manage, right? And I think the answer is correct. You will continue the buprenorphine. We don't have a drug to treat cocaine addiction, but you can do contingency management. You can do a variety of other things to try to support in that process.
Yep. And this again is exactly right. We don't have FDA-approved medications. Contingency management and other behavioral treatments are recommended. Really hard to do in the hospital. And also, if Medicaid, Medicare, and other insurance companies don't cover contingency management, really difficult to do. But a voucher-based system to kind of help support reduction in use. And but there is, and we wanted to just point out, this is also new in our guidelines, a reference to new guideline for management of stimulant use disorder that include tables about certain medications one could use in certain situations, even though they may not be FDA approved. And there's data about viral load suppression with contingency management. Thank you, Steve Shoptaw. And I just wanted to point out that this is the new recommendation in the substance use disorder guidelines too, that we added that as well. And I think I'm out of time, so I will end there. And I'll stop sharing and see if we have any other questions.
Yeah, that's great. Thank you, Sandy. One of the first questions here is there a withdrawal syndrome with xylazine? Is there anything we need to consider?
Yeah, so they are seeing withdrawal symptoms from xylazine. The problem is, of course, it's very complicated because often, unless the patient can actually say this is the only substance they're using, it's not so easy. There are some recommendations on how to manage that, but it includes management of their symptoms. We don't yet have a medication to treat specifically this particular problem. I think the big issue is a lot of us see opioid withdrawal as well as xylazine withdrawal, and then we're seeing benzodiazepines and other medications that are kind of adulterating that, and also that complicates everything. But there's urine drug testing for xylazine, so you can in many healthcare settings now. So if you don't have that in your hospital, just something that they can advocate for if you're starting to see that, and that can really help maybe make that decision that could be something that they're experiencing. Yeah.
Kristen Wagner is asking about mirtazapine, which could also be effective. Comment there?
Yes, it's true. And that's actually recommended in the ASAM AAAP guidelines that I just referenced, that might be an option for some of your patients.
Can you say a bit more about how you use mirtazapine in that setting? Do you have a sense how? Is it just during the maybe?
Yeah, so you could use it similar to how we would treat an opioid use disorder. It could be a medication that you can use to help reduce craving and use. It's not effective for everybody, and then we just have to monitor drug-drug interactions.
Standard dose, regular dose, nothing special about the dose.
Yeah, not any special, but there are certain situations with certain comorbidities that you have looking at the table about use. Yeah.
So Dr. Mossman writes appropriately that identifying the withdrawal is critical, obviously, in that situation. But sometimes getting to the drugs that we need to treat at some institutions is antiquated and difficult. For example, use of methadone. What are the ways that we can work through that if we don't have buprenorphine, that we at least got rid of all that training certificate sort of stuff with you used to have, but what are your recommendations for how to deal with these institutional rules that may block our ability to do what we need to do?
Yeah, so there is the 3-day rule. So if they're involved in the United States, if you can initiate methadone if a person has not been on methadone for withdrawal symptoms in your healthcare setting, in the emergency room, in the hospital, and so you can do that. I think some of the more challenging things, and I've even come across this myself, is individuals who've been on methadone in the community, where someone may not have. We have this rule where you have to call and you have to ensure that they have been on methadone at a particular site to then give them that exact dose in their healthcare setting. And if you don't show that or prove that, they cannot get the methadone the next morning. And that has happened to me in the VA. It's happened to me elsewhere, calling, the chief medical officer of the day. And it is an antiquated system. And I think we all have to collectively advocate for our patients. But in a new patient, yeah, you can initiate methadone in that situation. I remember the day when I was a resident and if you wanted to start them on methadone, we couldn't in the hospital unless you could ensure that they could continue to get methadone outside. But then we had methadone programs who were refusing to take a patient unless you could show that they had active opioids in their urine and they were actively using opioids. It seems so ridiculous, but that was what we were doing now. But now you do have the option that you can do that. Yeah. And that all makes a difference. Like, this isn't just saying off the top of my head, it makes a difference, obviously, for their opioid outcomes and death, but also from an HIV standpoint, it can reduce the risk of acquiring HIV by treating their opioid use disorder, as well as among those who have HIV will help them stay in care, stay on their medication and achieve and maintain viral suppression. So
I think your last statement underscores why this section is in the guidelines, because it is so critical and we see a lot of it. Dr. Resnick points out that for xylazine withdrawals, that this yohimbine from the veterinary world might be used to treat. I don't know anything about that. Have you used that before?
I have not, so I defer to that expertise.
I guess this is what's great about these conferences, is that there's a lot of expertise in the audience that really contributes, and
Absolutely.
very grateful for that. So we're really at the end of our time. We're going to take a 15-minute break and come back, and there'll be some music and a countdown so everyone can do their bio break, and we'll be looking for everybody back at 10 after the hour.